It is easy to know a person after frequent interactions, but it is really difficult to identify various shades of a disease, even after many years of clinical experience. So the trick in making a diagnosis is to see and interact with more and more patients and do seriously try to have more and more feel of their sufferings. In this clinical video, we will see and interact with meningitis. With these words, I am Dr. Manish and I welcome you all to the interesting and crisp clinical video. So let's start. A 11-month-old male child weighing 9.4 kilos presented with complaint of vomiting since one day and fit of uncontrolled movements since one day. On examination, temperature is 101.5 degree Fahrenheit, saturation is 94% in room air, and heart rate is 102 beats per minute. Child is unconscious with bulging anterior fontanelle and intermittent opisthotonus. Based on presenting complaints and examination findings, a differential diagnosis of meningitis and encephalitis is made, and complete blood count, CRP, blood glucose and lumbar puncture for CSF examination are ordered. Complete blood count shows decreased hemoglobin, polymorphonuclear leukocytosis and decreased platelets. CRP is raised, blood glucose is normal. CSF examination shows CSF to be turbid with glucose less than 50% of blood glucose with raised proteins and total cells with predominant polymorphs. Now, based on presenting complaints, examination and investigation findings, a diagnosis of bacterial meningitis is made. But what is the culprit organism? We still don't know till results of CSF culture is available. After all this workup, when it comes to treatment, one may often be in dilemma of whether to start treatment or not till definitive diagnosis is available. And the answer is yes, as delaying the treatment causes more harm than good. So this child is put on third generation cephalosporins to cover the most common bacterial causes. When it comes to meningitis, there are many clinical relevant points which should be remembered. Let's discuss a few in a question-answer format. First question is, what is meningitis? And the answer is, meningitis is inflammation of meninges covering the brain. Next question is, what are the causes of meningitis? And the answer is, viral infections are most common cause of meningitis and includes enteroviruses, Epstein-Barr virus, adenoviruses, and mumps. The best part from clinical point of view is that most are self-resolving. Next common cause is bacterial. When it comes to bacterial meningitis, it is important to know organisms according to age, as it helps in rational antibiotic selection. So organisms from birth to first 3 months of age are Group B Streptococcus, E. coli and Listeria monocytogenes. Organisms from 1 month to 6 years of age are Neisseria meningitis, Streptococcus pneumoniae and Haemophilus influenzae. And organisms above 6 years are Neisseria meningitis and Streptococcus pneumoniae. Fungal and parasitic meningitis is rare in children. Finally, non-infectious meningitis include malignancy and autoimmune diseases. Next question is, what are the CSF changes in meningitis and encephalitis? And the answer is, look at this table. So the abstract is, CSF is turbid in bacterial meningitis and clear in rest. Polymorphs are increased in bacterial, but in rest, either lymphocytes are increased or the white blood cells are normal. Finally, as bacteria eat glucose, so CSF glucose is decreased in bacterial meningitis. However, The exception to these rules is that lymphocytes can predominate in bacterial meningitis in Lyme disease, and glucose levels can be low in viral meningitis in enterovirus meningitis. Next question is, what causes more damage in meningitis, organism or host immune response? And the answer is, most of the damage caused by meningeal infection results from host response to infection and not from organism itself. Next question is, what are the cerebral complications of bacterial meningitis? And the answer is hearing impairment, local vasculitis, local cerebral infarction, subdural effusion, hydrocephalus, and cerebral abscess. Now let's see what complication we had in our patient. CT brain revealed hemorrhage in left basal ganglia and thalamic region with perifocal edema. There is also hemorrhage in right parietal region with perifocal edema. These complications are the result of local vasculitis. Finally, the question is, should hearing be assessed in patients with bacterial meningitis? And the answer is, all children with meningitis should have an audiological assessment done promptly, as children with hearing impairment may benefit from hearing amplification or a cochlear implant. That's all for now in this video. If you have any queries still left or suggestions, then do post in the comment section below. If you haven't liked or shared yet, then do like and share this video, and don't forget to subscribe. Thank you.